Afternoon, everybody. Can you hear me?
Yes.
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 Okay, very good. Because I have some technical issues, but if you are hearing me, that's the most important. I would like to welcome you all to this webinar. Thank you for joining in. Numerous and always with great interest, and actually the topic is really very important for us. It's about access to controlled medicine and how to overcome the existing barrier in low and middle income countries. A little bit of housekeeping issues. This webinar is being recorded, and this session will have interpretation. You can choose between 3 languages, so the original language English, or interpretation in French, Russian, and Spanish by using the drop-down menu at the bottom of the screen, where you see interpretation. It's important to mute the audio channel if the originals, if you want to listen to another language, so that you don't hear 2 voices at the same times. Also, we have a chat box, but also, and later a question answer where you could put already your questions, especially when you have immediate questions when a panelist is speaking. I didn't introduce myself. I'm Mirella Dumafrai, heading the Civil Society Unit in UNODC, under the direct supervision of the Director of the Division for Policy Analysis and Public Affairs. And later you will hear my colleague from what we call the Substantive Unit, the Prevention, Treatment and Rehabilitation section of our health branch, Elizabeth Mattfeld. If you don't mind, if you are listening, just mute yourself. This event is organized with the Vienna NGO Committee on Drugs, and I'm really pleased to be here opening this webinar with Eloisa Brogiato, who will moderate the session. At the moment, I think we had, as I mentioned, we have over 190 registration. I don't know how many. I'm still having some technical difficulty in overseeing this thing, but I'm sure many of you have joined. The Civil Society Unit, many of you may probably know us because we are a little bit the point of entry for civil society within UNODC. We facilitate your participation at intergovernmental meetings, including at the Commission on Narcotic Drugs. And we provide training, workshops to build the capacity of civil society in view of working with member states on the implementation of the convention and the commitments on on combating drugs and crime issues. And also it's important to hear your voice from the ground. This is really the essence of our work. At the high-level ministerial meeting in 2019, the member states have reiterated their commitment to strengthen the access to controlled medicine while avoiding diversion. As part of this effort, UNODC has a global program to assist member states, and you will hear in a few minutes more about it. I would like just to refer that this webinar is part of a series of webinars that we have been doing, thanks also to the contribution of the US Department of States and the Russian Federation. So I take the opportunity to thank both donors for the continuing support to UNODC Civil Society program. And I would stop here and give it give the floor to Eloisa. Thank you all for participating.
Thank you, Mirella. Good afternoon, everyone, and welcome to our webinar. I'm Eloisa Brogiato, and I'm a board member of VNGOC. I would like to thank all the speakers on behalf of the VNGOC and thank the Civil Society Unit, which is co-organizing this event. Before we start, I just would like to remind you how interpretation works. I think Mirella also mentioned that. So please don't forget to mute the original audio in English. And I also would like to remind the speakers that you are being interpreted. So please don't speak too fast so that the interpreters can send your message clearly. And I would like to start this webinar and giving the floor to our first speaker, Elizabeth Mattfeld. She works at UNODC in the Joint Global Program, a partnership between UNODC, WHO, and UICC, the Union for International Cancer Control. And since 2013, Elizabeth has been leading the efforts on a coordinated worldwide response to improve access to controlled drugs for medical purposes, while controlling for abuse, diversion, and to increase the number of patients receiving appropriate treatment. Elizabeth, please, you have the floor.
Thank you, Eloisa, and thank you very much for the opportunity to speak as part of this panel. I see some very esteemed guests, not only as panelists, but also in the attendees list. So I hope I do a nice job of opening the session. Let me share my screen. While I'm sharing my screen, let me also apologize a little bit in advance because I am recovering from COVID, so I may start coughing and my voice sounds a little funny, so I don't feel like myself, but I will do my best. Let me talk a little bit about UNODC's program on access to controlled medicines. As Mirella has already shared, this program does sit within the Drug Prevention and Health branch and the Prevention, Treatment, and Rehabilitation section. And for many people, that's a little bit confusing because obviously if we're preventing and treating drug use, we're looking at reducing supply. And, for me personally, it was also a little bit of a shift, but it becomes very apparent, and I'll talk a little bit about that as we go along, how those two things are intertwined. So in 2013, UNODC recognized that many of our partners, WHO as well as INCB, which is the International Narcotics Control Board, had already been working on putting out some documents and some information around this issue of access to controlled medicines. And if you go back, as Mirella had indicated, the mandates are very clear. They're there in the political declaration, the ministerial declaration, the UNGOC outcome document, and all three of the drug control conventions. In fact, it's in the first paragraph, the first couple of sentences of the 1961 convention, that we must make these medications available to patients who are in need. And so here UNODC decided that one of the things that we wanted to do was make it a joint effort. So as Eloisa said, we have partnered with the World Health Organization, and our civil society partner was very important to us in the beginning. We knew that this work could not be done merely with UN agencies. The key to this, and I will say it many times, not only in my mind, but also in the work that we've been doing, has been civil society partners. So the Union for International Cancer Control was one of the leaders that we knew had a strong voice at the international level, looking at patients and cancer care. And that was one area that we could link with, so that it's not that it's the only area, but it was an area that we could link with that was easy for member states to understand, easy for member states to engage with, easy for Ministry of Health to understand that those cancer patients are critical patients when it comes to pain relief. And so here, this was the basis for our joint partnership. We wanted to make sure that we had, the drug control component on one side, the WHO on the health side, as well as the civil society partners. I also, for those of you who aren't familiar with UICC, I do encourage you to please reach out and become familiar with UICC. They have an extensive network, not only at the international level, but also within the local, regional, and national level partners. So please do know that they are a resource for each of you as civil society partners as well. We focused on 3 areas since 2013. We looked at where is the consistency between what is the policy and what is the legislation. And for those of you who are already looking at this issue, already working on this issue, as I know many of you are, you know already that there is, even in country, inconsistency between what is the actual legislation say and then what is the actual policy. If you go perhaps to a country that has 5 teaching hospitals, all 5 teaching hospitals will be doing something different when it comes to controlled medicines. If you go to a place where they have a consistency amongst the education system, so we're talking about preparation of healthcare providers as well, they may be preparing their healthcare providers in one way, but their policymakers or the people who are reporting back to INCB may be reporting back on something completely different. So there's a disconnect. So the first thing that we wanted to do was look at that consistency. We also wanted to talk about education and capacity building. And here we know that it's really about supply and demand. You can increase the supply, but if you have no one who's willing to use the materials because they aren't well trained, the medications, if they're not well trained, or if you have people who are willing to use it, but they're not well trained, so they're not using it properly, now you get to a place where supply and demand are out of balance again. It's just in perhaps a different direction. And so this idea of education and capacity building has to happen in parallel with the idea of a supply chain being addressed. So most countries, with the exception of 5 countries around the world, most countries do not have adequate access to essential controlled medicines. And that's the full gamut, but mostly we're focusing on pain management, pain relief, medicines associated with palliative care. And so if you look at that, that means that most of the people in the world do not have access to what they need. And so the supply chain, we hear a lot about that right now with COVID, the supply chain this, the supply chain that. The supply chain for controlled medicines has been a challenge from the very beginning. And I want to spend just a few seconds talking about it for those of you who are interested in this. Again, it's a balance between supply and demand. So just trying to increase the supply does not work if you have people who are physicians who are not comfortable writing the prescription, physicians who are instructed not to write the prescription, physicians who write the prescription, but the families do not fill the prescription because of a sense of stigma or a sense of fear. And so one of the things that we need to be careful of is if we get into that kind of a circle of logic, if you don't have people writing the prescription, you don't have pharmacists filling the prescription, you will have no demand for that particular medication. And I can't tell you the number of countries where I go into that that's the actual case. They say, yes, we have lots of patients. We have lots of patients that are struggling, but we don't have any demand for the medication because we don't have anyone who is writing the prescriptions. We don't have any pharmacists who are willing to fill those prescriptions. Now, the pharmacists will say, because we don't have the supply. And the physicians will say, we're not going to write the prescription because we know there's a stock out. And so it becomes the age-old conversation of the chicken and the egg, which came first. What we, under the UNODC program, talk about is how do we make that balance? How do we balance supply and demand? We need to make sure as civil society partners that we are part of that equation. And so I'm going to, I don't want to talk for a long time. I know there's many behind me, but I just want, it's very, very infrequent that I get to speak to civil society partners about how crucial of a role you have to play in this conversation. So I just want to have my last few slides be really focused on that. So I'm going to look at what does civil society do at the international level, and what does civil society do at the national level. So let's look at the international level first. And we have a number of international partners on the call already. Catherine is a great partner, UICC is a great partner. We have many, many international partners, and they all come together to do a number of different things. This is not an exclusive list, or I should say an inclusive list. But one of the things that's super important about civil society is that you should know who your international organizations are. I can't stress enough that this is a small community. We have been doing this work for a long time. Most of us know and respect each other very well. And more importantly, the international partners around this conversation are extremely well organized. They have, they know who they are, they know what their roles are, they know what the messages that they want to focus on. So please do reach out, get to know them, and find out how you can support one, two, maybe all four of the big international partners fit in with the work that you're doing. Please do also know that coming up in March, we have the Commission on Narcotic Drugs. That commission this year is going to be chaired by Belgium. Belgium is a great support for UNODC and on this subtopic, and they are holding, I believe, at a minimum of 2 side events, and those side events will be a high-level event on Monday, and we will also have a event on Thursday. And so please do be looking for those events. I think Catherine will also be sharing about an event that she's involved with as well. The reason that I share that is that, again, because of COVID, we have a hybrid situation. And so we have more people who can be involved and who can reach out and be connected to this. You don't have the expense of traveling, all of those. So please do take advantage of that opportunity. International partners are a great way to advocate for the work that you are doing. Our international partners are always looking for how do we make sure that we get a good message out. And the way that we do that is to leverage what's happening with the local providers, the people who are actually doing the work. Nobody wants to see my face talking about things. They'd much rather see someone who's actually providing care to a patient, someone who is a patient, someone who has a voice that's a little bit stronger in terms of that advocacy area. The other thing that we are constantly looking for in this work is what are the best practices? What have you done that works? There is no, at this moment, body of work that says, here, you must do these things or else you will fail. We have a long list of things that people have tried that could be successful, but I think most of the people on this call are very well aware that every country is different. Every set of legislation and policies is different. Every approach is different. So there is no one way to do it. And we're always interested in collecting, what are you doing? How are you doing it? How can we help you? How can we celebrate what you've done? At the international level, there's a huge amount of resources, information, and so much technical knowledge that can support you in your work. And so please do reach out. Read the publications, check the websites, make sure that you connect and ask questions, but there is no reason to not have information. There are documents, there's a significant amount of materials that you can print, that you can share, that you can use as you're developing your work. And then the normative data point. I hope that others will talk about this, but it's really critical that we start to have some normative data where each country is looking at it from the same perspective, and our international partners and civil society has a huge role to play in that, and to help really bring that together. We've been published in terms of information with the Lancet Commission and a number of other journal articles. So I think that this is a key moment where if you are not collecting data, you need to start, and your international partners can help with that. Let me just talk quickly about the national partners, because I know Eloisa is getting a little nervous. Okay, at the national level, UNODC does work with national and local organizations. And so most of the time we get funding, it's for a particular country and it's for work in a particular area. So please don't feel like you can contact UNODC and say, we want to do this, we want funding to do this. That's not really the way that we're working at the moment. Maybe someday in the future, that would be great. But usually what happens is that we reach out to you at the local level and say, hey, how can you help us? We want to bring you in to this conversation. We do a lot of partnering with the health ministries. So please do make sure, if you have not as a civil society partner really engaged with the health ministry, that this is your chance, this is your platform. I will tell you that we have had a huge amount of success. We have very rarely found a health ministry that does not have an interest in this topic. They either have a access to medicines in general section, or they have someone who is just personally interested in this topic. So please do reach out to the health ministry. Know that you should be looking at many different parts of the health ministry. I'm sure we'll hear about palliative care in the next speakers, but palliative care is only one place to look for. The other area in the health ministry would be non-communicable diseases. The other area to think about with the health ministry would be sometimes where they talk about mental health or support or the non-traditional medicines. Those are also areas where we can bring in this conversation about how do we access the medicines for people who are really in need. You are also at the national and local level an advocate. You're not just an advocate for us or for the international level, but at the national and local level, you're also advocating specifically for the key stakeholders involved. So this is your chance to say, okay, I want to be focused on patients. And then you become a patient advocate, and that really guides your work. But you could say, I want to be focused on caregivers. And then you become an advocate for caregivers. And so the opportunities abound. So think about who are the key stakeholders, who do you want to be working with, and really be strategic and selective about, as a civil society partner, you can't do it all. What can you do well? Who do you want to work with? I can't say enough. Link to palliative care, link to the work that's being done around the world, but at the local level in this area. Not just because it's usually connected to cancer, but because these are well-trained healthcare professionals. And so if we only rely on them for what they do, we will not have enough of them. And so please do expand your vision, but learn from them before you expand your vision. There are many, many roles that palliative care expert can play. They can help emergency room people learn how to assess pain. They can help us policymakers understand what pain is and how we treat it. They can help a lot of people understand, families and caregivers, that this is a complex issue. This is not just give someone a medication and we're done, that there are many, many aspects that we need to look at in a very comprehensive way. I cannot say enough, the family and caregivers focus. So many of us focus on the patient, the needs of the patient, but families and caregivers are gatekeepers. If they don't understand the issue, if they don't understand the challenges, if they have misinformation about the medications, they will be the gatekeeper and they will not help you in this regard. So many family members are very fearful of using these controlled medicines, and so they will not do it. And in that case, you need to make sure that we share that information, that we educate them, that we increase that awareness. And the last area before I go on to my last slide is awareness and capacity building. We have worked around the world with, at the local and national level, with amazing civil society partners that take on their shoulders the role of really doing that capacity building. The civil society partners are the ones that are training the doctors, they're training the pharmacists, that are training the nurses to take on this increased awareness, to say, be good advocates, be the change agent, because our civil society partners have that capacity, they have that understanding. They're close to the people who are suffering, and this is a role that they have taken on. If that is what you want to do, please know UNODC has resources, information, all of those kinds of things that can certainly help, and we would be more than happy to do so. I want to close with just a little bit of an explanation for those of you who are my friends and what I consider almost family on this call. I've been working on this since 2013. I am currently on special leave from UNODC, but as always, this issue will be in my heart, and I will be advocating for patients and people around the world as much as I can. But the focal point for UNODC right now is Giovanna Campello, and her email address is on the screen. Please do reach out to her. And I'll just give a little teaser. If we get to questions and answers, I would love to talk about access to controlled medicines from the perspective of what medicines are we really talking about? Are we talking about access to pain relief? Are we talking about access to psychotropics? Are we talking about access to substances for drug treatment, such as methadone and buprenorphine? And so with that teaser, I will send it back to Eloisa, and we can address that in questions. Thank you.
Thank you so much, Beth, for this comprehensive and encouraging presentation. And we appreciate you being here while recovering from COVID. I hope you get well soon. Thank you very much. And now I would like to give the floor to our next speaker. Is Mark already there? Is Mark Fesiga? Fesiga already there?
Yes, I'm here.
Oh, hi, Mark. So Mark Fesiga is the country director of Palliative Care Association Uganda, and he advocates for human rights and justice for the vulnerable. He has a master's in management science, a degree in social science, and certificate in drug policy, diplomacy, and law from the Institute of Graduate Studies in Geneva. Mark, you have the floor.
Thank you so much, and it's great to be part of the panel. And for everybody who's listening in, I see some people from Uganda here, and of course, Dr. Anne. It's threatening to rain here, so I'm going to share my slides, much as I had not prepared them to share the screen. Just in case it rains, you can be able to follow because it's threatening to rain. I am going to be talking about mainly access to oral liquid morphine, and I'll focus on that for pain relief for patients in Uganda and highlighting our experience. And my request was that I speak about how we have been able to speak with to work with the police and the other human rights agencies. And just briefly about our organization, the Palliative Care Association of Uganda. We were formed in 1999. We are a membership organization. We have a vision that palliative care should reach all in need in Uganda. We work closely now with over 200 health facilities which are accredited to stock, prescribe oral liquid morphine. And recently, you've read about Uganda being top ranked in the recent research on the quality of death and dying, and I thought I'd mention that. It makes us look out that. You can look out for the report, for the article, and look at it. We actually, even in the abstract. This is what we do as the association, and we do 4 things mainly. We do capacity building, we do advocacy for palliative care into this country, we do resources mobilization, or what we call sustainability. We also support palliative care research. And we've been able to reach nearly all parts of the country, but we still have a number of districts, over 30 of them, without any form of palliative care, just like in the other developing world. A little bit of flashback on this issue about oral liquid morphine. I'm glad Dr. Anne Merriman is online, and maybe she will chip in at the end in Q&A to speak. From 1993, she introduced liquid morphine in this country, and I decided to speak on that because that's what I was asked about the committee that we set up. And the committee looked at other medicines, but mainly we were focusing on making sure that the patients who need this medicine can access it for their pain relief. And the Palliative Care Association already said when we were formed in 2004, the nurses in Uganda who are trained were allowed by statutory instruments to prescribe oral liquid morphine. In 2010, there was a stock out because of the arrangement that was there, which I cannot go into, that led to transformations in 2011. And now there's an improvement. Hospice Africa Uganda, which Dr. Anne founded, is the one manufacturing oral liquid morphine for the entire country. It is distributed mainly by the national distributor, the National Drug Authority supervises and regulates, the National Medical Stores distributes, and the Joint Medical Stores distributes to the private entities. The morphine shelf life has been improved or increased from to 1 year, and that helps us to even have it on the shelf for more time. What has been the role of this organization? Before I tell you our work with the police, we've been a stronger link to the ministry, to the government. I think she just mentioned about that. And this is very important to have an organization that links the key players who are advocating. We've been at the policy and the digital framework level doing that advocacy very strongly. Budget allocation to make sure that this medicine has enough budget allocation. Right now in our country, this we have succeeded because the medicine is manufactured and offered free of charge to patients across the country. Recognition and space for the prescribers, supporting training. This is very key. I'll mention it later on. More training means more hands, more professionals means more work. It means more reach, it means more access, and it means more people who need can be reached. Audience sensitized key stakeholders, the police was key, that's what you asked me to talk about, and then coordinate the morphine supply chain, the manufacturer, the regulator, the distributor, and the hospitals which receive this and give it to patients, and then support accreditation. Now in our country, we support the Ministry of Health to go down to accredit these facilities which can order, stock, and prescribe. It's a very huge role that we have as a civil society to support that, and we are proud about what we do there, and support data and information improvement. Now, these are the players. I won't mention this a lot because I think it plays out right about the same in different countries, but maybe what is unique here in Uganda is that because of the work of the Palliative Care Association, we have tried as much as we can to bring in all other players who we think are key. Now, we have the regulators kind of top, and the Ministry of Health can also be termed as a funder who brings in the money to purchase this medicine for the patients, but they also play a very important role in monitoring, support, supervision, and then also in the regulation. Hospice Africa Uganda is key, the hospitals, palliative care units across the country, and then we have the patients and the public, media, enforcement, and then the leadership. Now, our work with the police, the anti-narcotics department of the police, like I said, this was not to be like put out for everyone, but because of the show I'm sharing, so I've written a lot we established a committee on access control medicine in 2018. And this committee came up as a result of the conference that we held together. And I'm glad Catherine Peters is online and she was there to speak and to vouch out for the importance of this committee. The committee was mainly composed of the Palliative Care Association of Uganda, Hospice Africa Uganda, the Ministry of Health, National Drug Authority, National Medical Stores, the Uganda Police Force, Ministry of Justice, Ministry of Internal Affairs, the Uganda Prisons, and the National Referral Hospital. And these discussions were triggered by the Narcotic Drugs and Psychotropic Substances law that had been put in place in 2016. And we wanted to challenge the spirit behind the law, which was criminalizing all drug use, including the use of medicines that are controlled. And we pretty well succeeded. The committee continued to meet all the time, 4 times in a year. We've had issues with it now to continue meeting because of the funding and the challenges, but we've been able to raise awareness and yield more support from the partners. We've been able to ensure that the regulations for this act, which are in the offing, will come out to respect the principle of due balance. We've been able to input the standard operating procedures for the law enforcement. These are the police, because they were open. We were together with them, and so their operating procedures, when they're implementing this act right now, they are not tampering with the prescribers, because the act was not recognizing the nurses who were recognized in 2004 to be legal prescribers. And the information that we keep giving also help them from the leadership to the lower police to keep in check, to know what is happening. But there is a lot of work that needs to be done still there, because the majority of them down there may not know what we are doing on top, and we cannot do more trainings as we used to do, because we kind of had a funding issue there. Now reinforcing messaging and changing the narrative, bringing in the human rights people to make sure that the right to freedom of pain is key, and it's what we are talking about. And that work, we're working with the different stakeholders and the police, the Ministry of Internal Affairs, and the people of aviation, because that's what it means, the anti-narcotic police. These are the kind of lessons I put down. There could be many, but in 10 minutes, I can only mention what I put down quickly. Advocacy is key. Influencing from the top is key, because as we are working with law enforcement, for example, the key command, they command from top and it goes down very quickly. We need to bring in more players on board. That's a fact. The media is key. The public and people, spiritual leaders, religious leaders, people who have the pulpit to speak to the communities are key. More trained professionals, I mentioned this, means more hands, more work, and more reach. We need to see more trained, more health providers being able to appreciate that controlled medicine. And for example, morphine is not addictive, it is not to kill patients. It is important that this we do more. We need to seek more allies. Some of them who would be our allies, they don't really know. We have realized this in Uganda. I can talk about this maybe more in another meeting. You find somebody who would strongly support you, they just are not aware. The moment they hear about controlled medicine, they say it should be controlled. And once they get to know, they become stronger allies. Our continued monitoring is very, very important. We need to keep going is a big lesson. Even as our work, we don't need to relax. I mentioned that changes in funding affect the momentum in our case for some time, but we need to keep on tune. When you look, I just put a sneak peek of the essential medicines and health supplies list for Uganda. We have a list of essential medicines for palliative care included in that, and this document is reviewed periodically, and so we need to keep the momentum to make sure that once it is reviewed, we are still there and we keep moving on. I mentioned about involving high leadership. The letter from the WHO Director General to the President was very good. We were able to meet in meetings in a number of places, and engaging the President and at high level means a lot for the advocacy efforts. I think these are my last slides. This is the kind of work the WHO issued these documents at the end of last year. and our work was highlighted there. I needed to emphasize this point that data is very important. As we talk about access to medicines, access to controlled medicines, how do we make sure that we build our case? For the scientists who want to know, we are doing a project in Uganda supporting the Ministry of Health integrated data collection into the healthcare system. We need to do more around this, and it's my appeal to the rest of the countries which are listening in, especially the developing world, that we need to make sure that all our national data collection platforms can have these numbers, can have these figures. I just want to say that the need remains great. Thank you so much for this webinar. It's timely. We need to work together to make sure that people who need this medicine can access it. And I thank you so much for asking me to speak. Thank you so much.
Thank you very much, Mark. Thank you for sharing this important work you're doing in Uganda. And it was very interesting to learn from the work you're doing with the police. Thank you very much for your participation. And now I would like to continue with our next speaker. I will give the floor to Smriti Harana. She works for Palliative India, where she heads the policy, strategic partnerships and community engagement division. Smriti oversees programs on national outreach, advocacy, development and integration of curricula, health and gender equity, balanced access to essential opioid analgesics, and appropriate end-of-life and palliative care in humanitarian settings. She works closely with WHO to scale up palliative care in Southeast Asia region. So Smrit, welcome, and you have the floor.
Thank you very much, and thank you for inviting me to be part of this conversation. So globally, over 60 million people experience what we call serious health-related suffering. And of them, 9.9 million are in South Asian countries. And serious health-related suffering is greatly exacerbated by the absence of pain relief. So in 2015, WHO backed, in 2015, a WHO-backed study estimated that the average morphine equivalence, which is a proxy indicator of a country's palliative care provision, was only 1.7 milligrams per capita in Asia, compared with the global average of 61.5 milligrams per capita. So that pegs Asia's morphine per capita consumption at 36 times less than the global average. Major access gaps, as have already been highlighted, continue to exist. And in South Asian countries, they exist along the domains of service delivery, access to medicine, legislation and policy, professional education. And all of these are underscored by insufficient demand generation, because that is heavily influenced by the misperception that plagues opioid analgesics. But in the absence of systemic facilitation, initiatives driven by champions from within civil society, the medical fraternity, government and policy circles who understand the need for improved access to opioids has been a critical factor in improving access to opioid analgesics. Across South Asian countries, the availability of opioids, especially morphine, tends to be concentrated in big cities, usually the capital, and is markedly better in urban areas compared to rural areas. In some instances, healthcare is decentralized, and the implementation of national level policies is dependent on the will and capacity of local level governments. Now, while many civil society actors and champions have been key to the progressive changes to access to essential medicines that are underway in India, I'm here to share with you a snapshot of the work done by our organization, Palliative India, which is a non-governmental organization. And we work to integrate palliative care into mainstream healthcare, which sounds a little bit ambitious, to improve access to essential opioid medicines for pain relief. Now, our efforts over the last 18 years have led to substantial policy and programmatic changes at the national, subnational, and the community level. So I'm just quickly going to share my screen. So at Palliative India, we operate on a demonstrate, educate, and facilitate model. We demonstrate service delivery in the catchment of Trivandrum, which is the capital city of Kerala, where our headquarters are based. And we're a WHO collaborating center for training and policy on access to pain relief. We educate and sensitize the public and professional providers on palliative care through in-person and online trainings. And we facilitate palliative care delivery by engaging with national and state governments, public and private providers, as well as communities. And while we don't aspire to replicate the demonstration model in Kerala, we try to follow and adapt and adopt those principles. So enable practitioners to adopt components to develop solutions that are relevant to their context and build sustainability through their resources. And wherever necessary, adapt practices to selected components in their context, and adhering to principles and standards of appropriate evidence-based and ethical and rational practices, including palliative care. At our demonstration site in Trivandrum, we have so far seen close to 21,291 patients and their families through our inpatient, outpatient, and community-based home care services. And we have engaged the community in this regard. And we have upwards of, approximately 87 volunteers working in the community. Home care is a major part of our service delivery model because we believe in meeting people where they are when they need it. This often requires us to traverse some pretty challenging terrain, and really to take care into the homes of people who are not able to, for whatever reason, access healthcare services, either because of the conditions that they might have, or even because of other conditions like geographical challenges and so on. And also involve the community in not just providing essential medicines, but in extremely impoverished families also taking care of their food rations and things like that, because what use are free medicines when people don't have enough to eat? Beyond Kerala, we look at, we engage with people outside the city through our telehealth services. We run a telehealth service for palliative care. And between January and December 2021, we have had 1,385 patient contacts. While this is just one part of the service, for people calling in from different parts of India, we also have a directory of services that we're in touch with and link them to appropriate services where they can get hands-on care. So it's quite essential here. We all know about the principle of balance that has been talked about so much, where we need to balance out, international laws of criminal justice, prevention and diversion for illicit use, and at the same time ensure that controlled medicines are available for medical and scientific purposes. But as we all know, the system is still largely built around control and not access. And in order to, in our pursuit to strike this balance, we recognize that we have to work with professionals and capacitate them to this end. And through our training program, so far we have, in-person trainings, we have trained 970 doctors, nurses, allied healthcare workers. And we've done this at our own center, as well as by collaborating with state health departments in different parts of the country. And through virtual training, which was also stepped up during the pandemic, we have trained close to 2,800 people just through our virtual programs. And we've also collaborated with other stakeholders like the Public Health Foundation of India to bring training to 96 physicians, very senior physicians in the country who previously had no palliative care training. And so on the professional training front, in a lot of the South Asia countries, there are steps that have been taken to integrate palliative care education with the national medical curriculum, but this is still grossly lacking in most countries. And what this leads to is a poor understanding of and prescription of opioids. And in most places, opioid analgesics are the domain of oncology and surgery and are considered of little or no use in other departments and frequently met with active resistance. We found in several conversations with practitioners that respiratory depression which may be caused by serious overdose and toxicity of opioids, is misconstrued as a side effect of a therapeutic dose. So this also has this domino effect of poor referral chains. And usually, patients who require palliative care find out about it through other informal referrals or through other patients who've experienced palliative care. Ayushman Bharat, which is the flagship scheme of the government of India, was launched as recommended by the National Health Policy of 2017 to achieve the vision of universal health coverage. And under this scheme, the National Health Services Resource Center now aims to capacitate 450,000 frontline workers in palliative care, geriatric care, and mental health by 2020. And we were privileged to be part of this journey, and we convened a group of experts to design modules for all frontline workers, including auxiliary nurses, community workers, health officers, doctors, and nurses. And we also created videos that can be used as learning material. This has followed a cascading training model where people were trained at the national level who went on to train trainers at the state level, and then that sort of percolates down to the district levels. And this is quite a massive move by the government to make sure that at the primary level, people have access to palliative care, and a robust referral chain can then come into play. During the pandemic, one of the opportunities we had was following the World Health Assembly to actually incorporate the palliative care approaches to the management of COVID-19. And we basically broke it down. This was done in collaboration with a group of experts and physicians from all across Kerala and even outside. And it was a 5-day program with no paywall. And we had these 5 topics that we covered. And under symptom control, of course, we talked about the role of essential medicines and morphine in particular. And over a course of 25 batches, we were able to train 1,190 practitioners from 12 different countries. And the remarkable thing was that most of these people who signed up had no prior experience of palliative care. Many had not worked with opioid analgesics before, and actually went on to incorporating it into their practice. And another happy outcome was that this turned into a pretty effective advocacy tool with various state governments. And 6 state governments actually went on to issue orders to have more healthcare practitioners actually come and train under these modules. Of course, a very, very important component, like I said, is community engagement, because ultimately, why are we doing this? It's so that the end user, the community, has access to better palliative care and pain relief with controlled medicines. And so we have launched several programs to work with people with lived experience around several different areas, because the pervasive myths and misconceptions around pain relief, opioids, etc., is a major deterrent. So these are some of the themes that we work with to just bust the myths around palliative care, pain relief, and opioids, enable people to access palliative care services in their region, build awareness around appropriate end-of-life care through advanced care planning and things like that, and also to really bring them on board as advocates and for them to get involved in the delivery of services as volunteers. So really to hand the controls to the people who will benefit from it the most. And this is just a snapshot of one of those aspects of community engagement in Trivandrum, where volunteers from the community actually become our eyes and ears on the ground, and they refer patients to our home care services. And they usually take up a communal public space, like it's a primary school, which on certain days of the week becomes a link center for us to reach out to people who live in far-flung parts of the district. Now, major barriers to implementation, of course, include a lot of red tape, poor understanding of legislation, a lack of dialogue between law enforcement and healthcare providers. And so we engage with the central government and state governments to create or refine enabling palliative care policies and programs, which will then lead to a scaling up or a creation of an enabling palliative care ecosystem. And so far, we have engaged with the central government in many ways over many years. which did, along with other stakeholder involvement, which did lead to the amendment of the Narcotic Drugs and Psychotropic Substances Act, which is the law that governs access to essential narcotic drugs and essential opioid analgesics. And implementation of these amendments at the central and state level. And also it did finally culminate in the creation of a national program for palliative care, which we continue to pursue as, just to be implemented across the country. And collaboration with other stakeholders and other civil society actors in our country has led to the inclusion of palliative care now in the National Health Policy. And after many, many years, the inclusion of palliative care and its key elements in the undergraduate medical and nursing curricula, which was so far lacking. So this is how those gaps were bridged. And one of the key activities has been conducting opioid availability workshops across different states of the country. And so far, we've conducted 15 workshops across 14 states. And what do we do in these workshops? We invite stakeholders, from the health ministry, from the state drug controller, officials, and people from the National Health Mission, various departments, as well as physicians and other decision makers. And what we basically do in these workshops is to orient them to the need for controlled medicines for palliative care. We highlight what the barriers are and how they may participate in helping us remove those barriers. We engage and sensitize government officials about the amended law. And in many cases, we find that they have not been updated on that, or they're not aware of these amendments. And finally, to facilitate implementation by way of assisting people to get them to procure their licenses and to also renew them as and when required. And very, very importantly, to share protocols in how to safely stock and dispense opioids and other essential and controlled medicines. In the work required to ensure that the principle of balance that is enshrined in the conventions, we must take cognizance of the fact that the system is, like I said, still effectively built around control. What we really need is a large tent, which includes all the Ps, the professionals, the public, the policymakers, and the private sector, and underscore it with changing the perception on opioids and other controlled medicines across the board with all of these different groups of people. And in India, the medical practitioners have been raising the issue of harassment and misdirected investigations against entities engaged in legitimate operations related to narcotic drugs, psychotropic substances, and controlled substances for many years now. And so it's really important that when amending the laws pertaining to controlled medicines, certain safeguards have to be introduced in the procedures for things like, search, seizure, and arrest especially in the case of legitimate entities. This is to ensure that genuine entities like doctors are not harassed, and at the same time, illicit traffickers are proceeded against as provided by the law. I just want to end by saying that a detailed study has been conducted as way back as 2002, and to see if there in Kerala, and this was to see if there was any diversion or inappropriate use of opioid analgesics. In Kerala, we have close to 175 licensed facilities that report to the state drug controller annually, and he investigates any suspicious trends. And from 2002 to 2021, there has not been even one single reported case of diversion or inappropriate use. So there are tremendous examples where the principle of balance has been successfully achieved. And a common denominator that underscores all of these examples is a partnership between government and civil society actors. So I'll stop with that. Thank you very much.
Thank you so much, Smrit, for your great presentation. What you said is pretty important, the partnership with civil society and government to improve the situation on access to medicines. And with that, I will give the floor to Catherine Petus from IAHPC. Catherine is a Senior Advocacy and Partnerships Director for IAHPC and former Vice Chair of VNGOC and Civil Society Task Force member for UNGAS. So, Catherine, you have the floor.
Thanks, Eloisa, and thanks to UNODC for co-sponsoring this. IHPC is honored to co-sponsor this event. We've been working at CND since before I worked for the International Association for Hospice and Palliative Care, because we do work with the international organizations. So I just want to briefly introduce the International Association for Hospice and Palliative Care. We're a global membership organization. Our vision is a world free from health-related suffering. We work on 4 major areas of work: education, advocacy, research, and information dissemination. And I mostly work on advocacy and information dissemination. And what I just want to say, after listening to all these great presentations of colleagues today, with especially Mark and Smrti, whose countries I've been privileged to visit and go out on home visits with their palliative care teams and see what great work they do. And then listening to Beth in the beginning, we're all singing from the same song sheet, which I think is really interesting. And that song sheet involves including different actors and different partners who may not have known one another, who may not have had conversations with one another before. Smrti said, well, we need to have a big tent. The way I sometimes think about it is that we're creating new neural pathways, neural as N-E-U-R-A-L, neural pathways in society, just like neurologists know that the brain is plastic, and through new habits and new practices, you can create a different kind of psychology and state of mind in an individual. I think you can extrapolate that to the social level and to this area of access to medicines and access to palliative care. I also say we're changing the world one bedside at a time, because this is, as you can see from just today's very brief snapshot, it's a global movement for palliative care. And it's one of our visions. I always get mixed up with vision and mission, but it's part of our mission to create a global palliative care movement. And we're doing that through our advocacy and education and information dissemination, which is why we co-sponsored this video with UNODC, because it's information dissemination at a high level. So with that, I think we could go to question and answer, because I don't want to take up too much time, but I just want to thank everyone again, because this was a wonderful opportunity to showcase the work of these great partners. And also a quick shout out to Dr. Ann Merriman and Dr. Raja Gopal, because both of them were my original mentors, and it was hearing them at a conference 10, 12 years ago, speaking about lack of access to controlled medicines in their countries, that shocked me literally into this whole new career that I have now. I wouldn't have done it if I hadn't met them, and they're just terrific mentors and advocates for the whole world. So thanks to both of you.
Thank you, Catherine. And now we are going to question and answers. Does anybody would like to?
Louisa, I
yeah.
believe we have a few questions in the questions and answers section.
Yes, yes.
And I see that Elizabeth was already very busy answering a lot of them.
Yes.
But I do believe she said that she would like to highlight one of these also in for the wider group, in case someone didn't see the question
yes,
answered in the box.
Exactly. That's also my suggestion. So there is the question, the first question. So first of all, we just would like to inform that all the slides and the presentations will be, they're being recorded and they will be available at the VNGOC website. So you can watch it again or share if you like. And then there are two questions here for Elizabeth, and one is from Larry Kennemore. Sorry. He asks if besides opioids for cancer treatment, what about methadone and buprenorphine for treatment of OUD being so controlled that few physicians in the US offer treatment? An issue Rotary Action Group Addiction Prevention North America is working on. Yeah, and I think it's probably the case in many other countries. Please.
I wanted to take this chance to address three separate items, one of which is that, but I think also one of the things that I didn't say in my presentation that I want to say now is that for UNODC, we have looked at the barriers, and this call has been a lot of discussion about the barriers, but we've known the barriers for a long time. We've been talking about the barriers since before 2010. And so I would propose that we should start shifting the conversation, because the barriers are not going to change. They're always the barriers. And so as we shift the conversation, it allows us to not only shift, but also to address the question that is just being asked by Larry, but I think is a larger question. And then also the next question after that is also a larger question. So if you'll indulge me, I will answer both of them. So one is this idea of specific medications. And so what I've found at the international level is that every country has different legislation, different policies. And it's really important, first of all, if you aren't aware, there is international conventions that guide what countries must do. So please be very aware of what the international conventions are. That's what must happen. And then in addition to that, countries can have additional legislation that makes it even more perhaps difficult to maybe add some of those barriers. So in this particular question, it was a question about the US, but each country should be looking at their own specific policies. And so if you're not familiar, please do get familiar, because many of you on this call have a very general idea based on maybe what you hear from the US, but most of you have very different policies in place. So please do check those out. When I talk about this, we talk about essential medicines, essential controlled medicines. One area of focus is check your World Health Organization essential list of medicines and the essential list of medicines at the country level. That is both of those lists are areas where you can use that list to help you advocate for that particular medication. So in this question, you're asking about buprenorphine or about methadone, but in other countries, you might be looking for something else. So check those two lists first. The next thing that I want to say is, please be very, very careful and strategic, because for most countries around the world, we know that substance use and drug use disorders have some stigma, have some challenges that they're facing. And so yes, buprenorphine and methadone are both medications that are on that controlled medicines list. And sadly to say is I've been in countries where we've been having wonderful conversations. We're moving the government forward. We're getting the steps in place. As soon as someone comes in and reminds them that methadone is a controlled medicine, they shut the door and we don't do any more work in that country. So please do think about leveraging the conversation from the broader level, where you talk about access to controlled medicines, use the WHO essential medicines list, use all of the resources that says, and especially during COVID, people need access to the best healthcare, highest quality healthcare that they can get, and that includes controlled medicines. And if sometime in the future you get all of the legislation, the policies, everything in place, then you can advocate for maybe people who have non-communicable diseases, people who have cancer, people who have substance use disorders, because you will already have the tools in the toolbox. So I hope that that's one way of addressing something that we would ordinarily consider a barrier. And in this case, we can actually use it to leverage the work that we want to do. But you may have to take a little bit of a long-term view. The other area, the other question had to do with non-medical use. And I think that our last speaker really said it very nicely. In countries that have very little access to these medicines, the rational use of regulated medicines within the healthcare industry, within the healthcare setting, do not experience non-medical use. It just doesn't, I'm not going to say never. There are always exceptions. Somebody will always tell me, yes, but I know the nurses, you know, are using these medicines in a non-medical way. Of course, there's always an exception. But on the whole, we do not find that to be a problem. And it's certainly not driving the problem that people have, that different countries have when it comes to the non-medical use of substances. And I would go so far as to say, in some parts of the world, the fact that we don't have access to medicines means that people bring in or find a way to treat their own symptoms. And they often access medicines that they find in a non-regulated market, or maybe an illegal market, or maybe an illicit market, depending on the words that you want to use. And so I loved what Mark was saying, because Mark was really critically bringing in that law enforcement component, which we must have, because that law enforcement component needs to be regulating or keeping at bay the illegal or illicit medications that are very harmful for people, and not just the use of those medications, but you don't know what's in them. You don't know if it's a fraudulent or falsified medicine. So we need to make sure that people can access high quality, safe and medications for their particular needs, not for self-medication kind of purposes. And so please do know that in a regulated market, we do not have that non-medical use challenge that most people presume or fear that we have. So the pendulum can swing both ways. Right now, we have a lot of control in many countries. We're worried about it swinging too far to the other side. Absolutely, we want to find that place in the middle. In some countries where we have had too much access, perhaps, now we're swinging back to a place where we don't have enough access for the patients that actually need it. And I can use an example of my own. I'm from the US, and my brother-in-law recently passed away, and he was not able to get access to medicines, even as a patient in palliative care. And that's really frustrating in a country that we know should have access for the patients that need it. So I hope that that addressed, you know, those three big areas, and I'm sorry if I took too much time.
No, thank you very much, Beth, for your answers. And there is also another question that is addressed to any of the speakers. I think Beth also answered that in written, but if anyone else would like to comment. This is a question from Mercedes Bernada from Uruguay, and she would like to ask any of the lecturers to address the topic of access to kids-friendly presentations of morphine and other controlled medications for medication for pain relief for children in low and medium income countries, and if they know any global initiative to promote a fairer distribution of pain medications, medication for children by the pharmaceutical industry. Does anyone would like to comment? Otherwise, Beth, can you? I can't hear you.
I think Catherine raised her hand as well.
Yes.
Catherine, you want to talk about pediatrics, or you want me to?
No, I want to talk about something else. If anyone's going to answer that question, I'll go next.
Okay, let me just say, I can share what I typed in the answer for the pediatric folks. There is an international organization that is the International Pediatric Palliative Care Network. They have a significant amount of work around the world, as well as resources that you can access. They have a website. I've typed that into the answered questions. You can find that there. It also know that WHO put out guidelines for working with pediatric patients and pain medication. However, I understand are updating those. I do not know if they are officially out with new guidelines. So please do be cautious if you're using the old guidelines, because they are working on updating those. But also keep in mind that each of the countries has different policies and different ways in which you have to go through, again, those regulations in order to access that. So some of the medications that you might be wanting, you need to check those essential medicines lists to make sure they're on the essential medicines list, to make sure that they are legally able to be imported and used in the country with children and standard medical care. So there's a lot of steps that you might need to go through for that. Thank you.
Okay, thank you, Beth. And thank you for the questions. And now I would give the floor to Catherine.
Hi, thanks, Louisa. Really briefly, because I was just asked to give some brief remarks at the end, not to make an actual presentation. But Beth had mentioned that we're organizing a side event at CND, and we're organizing one on access to controlled medicines in the Caribbean, because there is a great disparity between the different islands in the Caribbean. So we'll be doing some publicity and media on that before March. And I also wanted to say, for those of you who might not already know it, and I think you already do, that this is an absolutely huge topic. And this webinar is just the tip of the iceberg. But the International Association for Hospice and Palliative Care, we have a modular or 6-module advocacy course. It may be closer to 8 or 10 modules by the time we're done, on how to do advocacy for palliative care. And the modules 2 and 3, which have already been released, are on advocacy for controlled medicines. So have a look at our website, sign up for our newsletter and our special announcements, and better still, join us and become part of this global palliative care community, so that you can take this course, because we do the kind of work to help civil society organizations around the world to have these interdisciplinary kinds of conversations with providers, prescribers, regulators, narcotics police, as Mark mentioned, and as Smriti both mentioned. This has to be a multi-sectoral conversation. And we have some experience doing that, and that has shown, the evidence is now showing that those have resulted in higher consumption. The UNODC World Drug Report results that were reported in 2021 showed that the countries where we have been doing that kind of work have increased consumption and awareness. So it's a slow process, it's an organic process, but it works. And it's one of the few things that does work, because as Beth said, the barriers will always be there. So thanks again for the floor. I'll take myself off.
Thank you, Catherine. Let me see, is there any?
I could say some last words, considering that we have approached to the end of the session.
Yes,
we spoke a lot about partnerships, civil society, government, UNODC. This is exactly why we are here. And myself being a staff member for a long time in UNODC, I had the first time heard of the access to controlled medicine and the need to address the unintentional consequence of the three drug convention, even probably before Catherine. So it was in the early 2010. And again, I can really say, because that there has been a lot of progress, and a lot of progress thanks to organization, NGOs like the one where Catherine, the Cancer Union that was mentioned by Elizabeth. At that time, they were the one promoting this campaign, please don't let me suffer any longer. And through awareness and a lot of the work that we have heard today, the agenda has advanced so much. Of course, you don't see it. People say there's still more to be done, but within the international community, and the progress is slow, but is certain. I mean, we can see it. So I would like, if you allow me, Mrs. Chair, to thank everybody for having participated, and the last word with you.
Yes, thank you, Mirella. And I can see now a question in the chat from Annie Merriman. How do we address the delay in referring the palliative care by doctors and nurses in the developed world, where many doctors and others think it should only be brought in when the patient is near to death? These doctors, nurses are not trained in palliative care, and who can help those with early cancer and severe pain? This happens in the developed world. Oh, it's more a comment. If anyone would like to comment, it's also open. Oh, Catherine.
Mark, you go ahead, because I was going to say you and Smarty have a lot of experience with that. And I would just say quickly, education, 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 as we've been all saying, but I'll give you the floor. It's those kinds of dialogues and trainings that we've been having, but that's enough.
I think that's the point, it's education, but we realize that we can't educate everyone at once. And it's a huge thing to say, we educate, but we need to continue to share what others have been through, to bring people who have had an experience, and even go out and involve the media and share the stories. And I personally have had an issue. My father has been receiving palliative care, and he sees one specialist in town who tells him, I told him my father sees a palliative care nurse, and they said, why did you have to bring him onto palliative care? You had to wait until I refer, or I decide that has to be. I say, no, his condition has to be like from the point of diagnosis up to this moment. And walking a journey with him as a senior consultant in town has taught me that I think we need to do more than what we say, educating the health workforce, maybe work with people to tell the story and even write about it in the media, write opinions in newspapers, and go out and even speak to the community, such that even the community can ask for what they think they need, other than waiting for an opportunity to be referred by a specialist or a consultant who may have no idea. And through that way, I think it's re-socialization, as we say in sociology. It will be maybe the community also participates in letting people know. And the question about herbs and herbal medicine in Africa, that's a big deal. I saw it in our traditional society, in where we live every day. People will use the herbs. I think Dr. Anne and everybody, when they speak about culturally appropriate palliative care, it's very important to recognize that, even as this care is being offered. That we need to work with the community in a more culturally appropriate way and to make sure that what works can work for them. That's the comment I can give. Thank you.
Thank you, Mark. And now I think Smrit would like to comment also.
Thank you. I just wanted to reiterate some of the points that Mark made. Of course, that education is important, but also the way in which that education is framed. We need to step out of the echo chamber, really. And one of the things that has worked quite, I think, is working well with in our experience is, zeroing in on certain specialty groups. So at the moment, we're running a program for pulmonologists specifically, and the use of opioid analgesics also for breathlessness and other such issues. So really finding the entry point with other specialists. We know now that there is there's a groundswell building in India for neuropalliative care, and it's when we have these doctors become advocates for the palliative care movement, that's also a way to get past this barrier. Because if it's only the palliative care providers talking about it, very often we come up against the same walls. But finding these champions in other specialties has really, I think that's what's going to take us forward. And coupled with, like Mark said, demand generation from the community. And those have to happen, again, like he said, with storytelling, with engaging them, give people an opportunity, people with lived experience, an opportunity to really speak up for themselves and, get them to share what their needs are. And I think that sort of a multi-pronged approach can help us overcome some of those barriers that we're currently facing.
Thank you so much, Smrit. And I still have 2 questions here in the Q&A. Do we still have time for that?
I think we're very much close to the end. It's already 4:30.
Yeah, okay. But the questions are answered. So if anyone, the questions are already answered. So if anyone would like to follow and follow up and read them, and
I would suggest that we also share the questions and answers with the participants in an email after the event.
yes,
So in case anyone missed any of the questions and the corresponding answers,
okay.
they can find them in the email afterwards.
Okay, that would be great. So so I think we could close the webinar. And I would like to thank one more time the Civil Society Unit, the speakers, and the audience, and a special thanks to our interpreters. Thank you very much. And good afternoon.